So for the next 20-30 minutes, I just wanted to go through some of the sort of key concepts of neuroendocrine tumors. Some of you may have seen this before, so I've updated the slide deck a little bit, added things, deleted things. And at the break, by all means, if you have questions, if you feel like I didn't address a topic, just find me and I'll try to answer your questions. So start with my disclosure. So I do a lot of work for different pharmaceutical companies, but it's almost entirely goes to my institution. So these are some of the top issues that I wanted to discuss.
Sorry, Dr. Thor. Just that microphone's a little short for you, so just make sure that you're.
Oh, sure. But if you don't hear me, like yell, raise your hand, throw things at me. I'm all good with that all. So the few of the topics I want to discuss are listed there. So I know there were only 5 major topics I was given, but I did expand it to some subtopics too. So and we'll just dive right into it. So the first question I always ask myself when I see someone with a new diagnosis of a neuroendocrine tumor is that do we really know what we're dealing with? The nomenclature, the naming of these things is complicated. Did we make the right diagnosis, or because if we didn't, we're not going to be giving you the right treatment. So the nomenclature of neuroendocrine neoplasms is really confusing. So we used to call these NETs, and as reflected in our professional organization, NANETS, which is then back of the room, the North American Neuroendocrine Tumor Society. So, but then NETs is only a part of the neuroendocrine spectrum. So I sometimes think of the Humpty Dumpty when he said, when I use a word, it means just what I choose it to mean, neither more nor less. The question is, as Alice said, whether you can make words mean so many different things. And it's been an issue with the neuroendocrine tumors because the nomenclature has been sort of going back and forth. You go across the pond to Europe and things may mean something different there. But I think we're all getting to the same page, so calling things the same names. So neuroendocrine neoplasms is really, or the NENs, is really an umbrella term that is inclusive of both the well-differentiated neuroendocrine tumors and the poorly differentiated neuroendocrine carcinomas. So NENs stands for neuroendocrine neoplasms, NETs for neuroendocrine tumors, NECs for neuroendocrine carcinomas. Do we really need 3 terms for this? And actually we do. So a neoplasm is essentially just an abnormal mass of tissue that results when the cells are dividing more than they should, and they're not dying when they should die. A tumor is pretty much the same thing, but the neoplasm is just a more inclusive term. And the carcinoma is also a tumor, but this is a tumor that doesn't respect any conventional boundaries. It can actually travel to other parts of the body, and so on and so forth. So what are NENs, or neuroendocrine neoplasms? So these are malignancies, these are cancers. I think it's best to get that straight because I still hear this from practitioners. They say, well, it's not a cancer. Well, all of these are cancers. They all have the capability to spread and metastasize, although some of them never do. So we know that some of them can sit quietly in the pancreas for 10 or 15 years and barely grow and not spread, but some of them spread early, and some of them actually, it's surprising that you can have a tiny little tumor in your small intestines and the liver that is full of metastases. So there's not a good sort of correlation between the size of the primary tumor and the amount of metastases. So they are extremely heterogeneous. You can have a neuroendocrine tumor that are like so slow growing that you barely see any difference over the years, and you can have other tumors or neuroendocrine carcinomas that are extremely aggressive, among the most aggressive cancers we see in humans. So, for example, I saw a patient not too long ago who came in with a liver tumor that was, I think, about like an inch and a half. New diagnosis, and so I was able to dig up a CT scan done for a kidney stone like 13 years prior. Had grown by like 6 millimeters in 13 years. So we said we could wait another 13 years and scan you again. And so obviously we didn't do that. But I'm just saying that they can be extremely heterogeneous in the way they behave. And they can start anywhere in the body. I've seen a neuroendocrine tumor start in any organ of the body except the placenta. And they can really occur anywhere. And I'm not talking much about, I'm actually not talking at all about what's called the epidemiology or the number of new cases, but we're seeing a huge increase in the number of new neuroendocrine cases in the US. So as an example for the pancreatic neuroendocrine tumors, when I first started looking at this as a fellow in my training probably 15, 20 years ago, and then we looked at it again in that time frame, like 20 years, we're seeing like 10 times as many pancreatic neuroendocrine tumors. It's not because they're becoming more common. I think it's because our scans are getting a lot better, and the awareness of patients and the providers is getting much better, largely thanks to organizations like NCAN and others. So the diagnosis, it's really a team effort. There's not, I know that we sometimes think of like neuroendocrine experts as individuals like myself or someone else, but it really is a team effort. And if I don't have a good pathologist, I am worth nothing in the clinic to you. And and we need radiology, other specialties we call in as needed. Let's say if it's a lung neuroendocrine tumor, we may need the lung specialist. We may need a gastroenterologist, or who knows. So we might need different team members for different patients, and we just assemble the team as we go. So the role of a pathologist, I've got to talk about pathologists because being married to one, I have to make sure that I do present the role of pathologist. And but pathologists are really the critical component of this team, because if I don't have the diagnosis right, all of my recommendations are worth very little. So, and why is this an issue? Isn't this something straightforward? You need a microscope and a pair of eyes, and it's actually much more complicated than one would expect. So there are studies from Europe suggesting that among new patients with new diagnosis of neuroendocrine tumors, up to 20%, 1 in every 5 of patients has a wrong, not necessarily a wrong diagnosis, but they have a wrong tumor grade or even a totally different tumor. And this even happens to the best pathologists out there. And sometimes pathologists don't even agree. And for certain neuroendocrine tumors, like the well-differentiated grade 3 neuroendocrine tumors, which we won't talk much about, even expert pathologists disagree 30-40% of the time. You can show the same slide to the 5 best pathologists in the US, and they may not always agree. So we need really good pathology. So let's talk about tumor grade. So you've heard about tumor grade. So a tumor grade is really a system to predict how aggressive a cancer will behave. It doesn't just apply to neuroendocrine tumors. All cancers are graded pretty much. And for the neuroendocrine tumors, we use a special method for this. I'll show you a picture in the next slide. So we use a stain called KSE7, sometimes called MIB1. And so we stain, it's essentially like paint. So we take a little slice of the tissue, we slap the stain on, we run it into the microscope, and then we count the cells that actually stain brown or stain positive. And that really determines how aggressive the tumor is. So this is how it looks to the pathologist. So on the left-hand side, you see a grade 1 tumor. You see all of those little blue dots. These are all cancer cells. You see a few brown or reddish-brown dots there. So these are the cells that are actively dividing or multiplying. So very, very few of them are. Most of them are just quietly sitting there in a resting state, not doing much. So on the right-hand side, you see that pretty much everything is brown. So that means that all of the cells are actively dividing, multiplying, and that would be a grade 3 neuroendocrine tumor. And the determination, or what determines grade 1, 2, or 3 is really the percentage. But as you can see there, grade 3 tumors is anything above 20. So there's a difference between 21 and 99. And so a tumor with a KS7 of 99 is typically a much, much more aggressive tumor. And the higher your percentage goes, the more aggressive the tumor is. But that said, we have seen patients with high-grade tumors with KS7 in the 40s, 50s, and 60s with surprisingly slow, sort of indolent, quiet behavior. And then we've occasionally seen tumors at the lower end of the spectrum that behave very aggressively. So the NETs can be among the slowest growing. So this is would be my sort of picture of grade 1, while this could be a grade 3. But some of the grade 3s don't really move that fast. Some of the grade 1s may move a little faster than a turtle. Well, what is differentiation then? So you hear this term gradient differentiation. These are really very strongly related. So the higher the grade is, the more likely you are to have what's called a poorly differentiated tumor. So the differentiation really means how much do the tumor cells look like the cells they originated from. In other ways to look at it, how angry or aggressive do they look? So do they look quiet and sleepy, or do they look very aggressive? And all of the grade 1 and grade 2 neuroendocrine tumors are well differentiated. And this is a little complicated, so all of the poorly differentiated neuroendocrine carcinomas are grade 3, but not all of the grade 3 neuroendocrine tumors are poorly differentiated. So, and this is something we only became to understand a few years ago, is that the grade 3 neuroendocrine neoplasms can either be well differentiated, often slow growing, or poorly differentiated, almost always really fast growing and aggressive. And they shouldn't be treated the same. And this is probably where pathologists get it wrong most often. So even our pathologists sometimes don't agree. And what happens then if the pathologist is not sure? So at Mayo, for example, they may end up showing the slides to 3 or 4 of their colleagues in the office, and then they come to a conclusion as a team. Yeah, we actually have, as a team, decided that this is a well-differentiated grade 3. Well, let's talk about the imaging team. So the imaging team is more complicated than one would think. So you need, obviously, expensive, fancy equipment. Everyone has that now. You need an expert radiologist to read this, but probably the team members that get the least credit are the techs. So if you have a CT scan and the tech is not good, then the scan is not very informative to me. So I think the tech should get much more credit than they do, because it's really, if you see a beautifully done CT scan in terms of like the imaging, the credit goes to the tech. So everyone has fancy imaging. As I sometimes say, everyone has a fancy scanner. Not everyone knows how to use their scanner to the fullest extent. So it's really crucial for us to have good imaging, and we have 3 main imaging types. So we have the CT scan, still the workhorse in the clinic. There is really a carefully done triple phase CT or dual phase CT, where we do arterial and venous imaging, is absolutely an amazing imaging study, and which is probably what I rely on 80% of the time in my clinic. So we have an MRI. MRI is definitely superior if you need really precise liver imaging, but then you need to think about what type of contrast to do. But then when you go a little bit further down in the abdomen, that's where the MRI gets a little trickier to read. Not impossible, but a little trickier. And then we have the PET scans. So the PETs, for us at least, come in 2 different flavors. We have what's called the somatostatin receptor PET, which you hear referred to as a dotatate PET or a gallium PET or a copper PET. All of that terminology should be abandoned. These should be called somatostatin receptor PET scans or SSTR PETs, because what we're doing is really we're labeling the tumor cells in the body with a special like a PET, what's called a PET tracer, and it's essentially just looking. So the way it works, what I tell my patients, so we give you a chemical that sticks to the surface of the tumor cells, like 2 pieces of Velcro. And then on that chemical, we put a tiny little like radiation tag on it. So now we have this chemical that sticks to tumor cells and this tiny little attached radionuclide, or the little the radioactive tag. We put this into your body through the vein, and like I sometimes joke with my patients, we let you marinate in this for a few minutes, and then it floats around the body. It sticks to the tumor cells wherever they are. Then we just take a picture of the body, and we see where did it stick, and that's the PET scan. The other PET scan we use is called a metabolic PET or an FDG PET. So this is really looking at the aggressiveness or the metabolic rate of the tumors, and that's what we use for the higher grade tumors. An FDG PET, which is the common PET you use for like lung cancer and other cancers, we don't really need for most neuroendocrine tumors. So how does this look? So here we have, this is the same patient. All of these scans are done literally done the same day. I don't think I have a pointer here, but you can see on the left-hand side, this is a PET image, and you can see that the big green thing there is your liver, and it looks mostly normal, but you see those little red dots in it. So these are the liver metastases. And in the middle part of it, you see the arterial phase, and you can see that there are, I think I did point them out here. So you can see there are little like brighter dots. So these are the liver metastases. But then if you do the venous phase of the CT scan, then you see that those brighter dots are all disappearing. And if all you get is a venous phase CT, you might actually miss all of the tumors in the liver, because then the contrast went in, or the scans were done too late. So this is actually, again, where the tech comes in. So moving on, so this is one thing that I warn my patient. I tell them, we're going to look at your PET scan. I'm going to warn you, this might be startling. And let me just walk you through this. And so the first thing, and I tell them, I'm looking for like something that looks like red or orange. Well, here you can see two big red things. These are your kidneys. These are normal. And then you see that other red dot there that lights up really bright. So this is a pancreatic neuroendocrine tumor. And people look at this and say, oh my goodness, it's huge. It's bright and huge. And then I pull up the corresponding MRI. So that, you see that little white dot in your pancreas? So this is actually the tumor. It's only a fraction of the size of what we're seeing on the PET. So the PET is like looking at a light bulb. It's like everything lights up with a huge halo around it. And the actual tumor is tiny. And sometimes I tell my patients that the tumors can be much, much smaller than they appear on the PET. This is why you cannot use a PET to measure tumor size. So you have to be really careful with that. If you really need information on the size of the tumors, then you have to get a CT or an MRI. And sometimes you can do them together. So we use SSTR PETs to evaluate bone metastases. This is actually one of my patients. I warned her these scans are going to look scary. 2019, 2021. So we see a lot of new metastases, but this person was entirely asymptomatic. So there was progression. We had to do PRT, which we did, and that worked really, really well. But all of these spots in the bones, I would not have been able to see with a CT scan or an MRI. So you have to, for each patient, you have to figure out what is the appropriate imaging study for that patient. So that's why if you talk to other people with other patients with NETs, and they say, I went to Mayo and I got a PET scan, but all I got was a CT. And that's, for you, the CT might have been the most informative study. For that other person, the PET was more informative. And sometimes you just need both. So sometimes you pick up unusual metastases, like to the breast in the left upper corner. I saw a patient, I've actually seen a number of patients with metastases behind their eyes. We treat with very, very targeted radiation treatment. It works really, really well. And then we're picking up a lot of metastases to the heart. So that's the lower right image there. You can see that that's your heart in the middle of the chest and that little spot. So we're picking this up all the time with PET imaging now. I've never, ever, ever seen it cause any problems. This is not the same as carcinoid heart disease, though. That's a different thing I won't have time to talk about. So who determines the stage? So it's really the treating clinician, your NET or your oncologist, but they can't do that unless they look at the pathology report. They have to look at how many lymph nodes were involved, and they have to look at the scans to see if the tumor has gone to other parts of the body. And sometimes we need like fancy additional imaging, endoscopies, and things like that. So what is tumor stage? So it's really a way, another way to predict how tumors will behave over time. So stage 4 disease, stage 4 tumors are typically more sort of aggressive, need therapy. Stage 1 maybe not. So stage 1 is localized. Stage 3 is what's called locally advanced. Stage 4, which is the highest stage, is when it has gone to other parts of the body. So the way that works, here you can see the stage 1 and 2. This is for colon cancer. It's not specific to NETs. That's where the tumors are limited to the colon. Stage 3 is now the tumors are into the lymph nodes next to the colon, but they haven't made it any further than that. Stage 4 is now the tumor cells have left the colon, have gone to the lungs, bones, liver, and other parts of the body. So that would be stage 4. So then the other question we get a lot is this tumor what's called a functional malignancy? Is it a functional tumor? And what is a functional tumor? So a lot of neuroendocrine tumors can make a lot of chemicals, stuff. If those chemicals are not causing you symptoms, they are what's called non-functional tumors. But you can get incredibly symptomatic from some of those chemicals. You can have a relatively small tumor that produces a lot of hormone, like let's say insulin, that drops your blood sugar all the time, or a hormone called gastrin that causes a lot of diarrhea and heartburn. But you can also have a tumor that produces gastrin, but the person has no symptoms whatsoever. Then that's technically a non-functional tumor. Almost all of them are what's called well-differentiated neuroendocrine tumors. So moving on to the next topic. So do I need to see a NET expert? And my question is always, what is a NET expert anyway? And if I were able to define a NET expert, how can I find one? And so the problem is that there's no standard definition of a NET expert. So I say someone who sees a lot of NETs and is good at it. And then the question is, how much is a lot? So some NET or NEN experts are really active in research, but you can have a really, really good NET expert who is not necessarily involved in research. But I think most of us do research to some extent. So similarly, there's really no good definition of a NET or a NEN center of excellence or expert center. So the Europeans have this. They have very, very strict criteria. If you are going to be a NET center of excellence, you have to you have to check all of these boxes. Do you have this, and that? And only if you have all of those things, you can be a NET center of excellence. We have never done that in the US. And I'm not necessarily sure if we need to. And but neuroendocrine oncology is really complex, multidisciplinary, and you need all of those team members I mentioned earlier. And it's not until you have all of those team players, or at least access to all of those team members, you can call yourself a NET center. And how do you find a NET center? Well, there are lists out there. They're not great in the sense that they are. There's a lot of subjectivity there. So who is on the list? There's people who are not listed who are really good, and then there might be people listed who are maybe not really true NET experts. But that's where the patient advocacy groups like NCAN really come in. They will know where the experts are. So why see a NET expert? Well, it's because it's an uncommon malignancy. The typical sort of average community oncologist may not see a lot. They probably all have seen some. And then a NET expert may have access to advanced scanning, testing, clinical trials, and things like that. But we also like to collaborate with your community oncologist. That's actually at least how I operate. I don't have to treat everyone at Mayo, but I want to be involved when needed. So sometimes I tell my patients, ask your doctor, your new oncologist, these questions. So what is your experience managing patients with neuroendocrine neoplasms? And are you sure you have the correct diagnosis? So these are things we discussed before. Are there more tests needed, such as additional imaging or molecular testing? And should I seek an expert in management of patients with the neuroendocrine neoplasms? It's a very important question to ask. And then, if I get an expert opinion, are you willing to work with that person? And if your oncologist says no, then you might want to find another oncologist, because it really is a team effort. And so we really want to, the expert centers, we really just want to make sure that we have the right diagnosis and be available at crucial time points. So for some of my patients, I say, I don't have to see you again, but I want to know if something is not going right. If your oncologist tells me, well, things are not looking good, things are growing, well, that's actually where I can come in and suggest on treatment. So why tumor boards? You may have heard of tumor boards, and essentially that's because more brains work better. So these are meetings most NET centers have now. So we have them every other week at Mayo, but we do sort of mini tumor boards all the time outside of that. So we bring in the challenging cases, not typically the routine sort of more no case is really simple, but not every case needs to be a tumor board. Because if we do present every case at tumor board, we won't have the time we need for the complex cases. So we present the complex cases where we really need what's called a multidisciplinary evaluation. And my sort of rule is that if it's a really complex case, we present at tumor board, no one makes a move until after tumor board. So until we have everyone weigh in. And so why do we do this? Well, I think we can cut down on your office visit. So instead of you having to see a surgeon, we can actually discuss your case at the tumor board. And if the surgeon say, no, I don't think surgery is needed, or I don't think surgery is appropriate here, then you are not coming for an extra visit to meet with a surgeon who tells you in 30 seconds that surgery is not needed, because we just decided that at tumor board. And also, we can see if there are clinical trials for you or who you should be seeing next. And just recently, there was a really interesting study that looked at patients who were presented at tumor boards and found out, yep, so I'll wrap up in 5 minutes. I like to talk. So sorry, I warn you, I could go on for days. And so the tumor boards actually improved the outcomes of therapy. There was a really, really good paper just published a few weeks ago, not for NETs, but for tumor, for all cancers in general. And patients who are presented at tumor boards, they seem to have a longer life expectancy. So it's not just that we like to get together for morning coffee. It's actually all virtual now. You just do it in your shorts, you have a tie on, and shorts, and so from home or whatever, however that works. And and actually the virtual tumor boards work great because now the surgeons can actually call in. They sometimes do it right outside the OR. When they're done, they just go into the OR. And hopefully this will translate to fewer visits. So I wanted to touch on multiple expert opinions. And this is something that is fairly common in the neuroendocrine population. So obviously you have a rare tumor. You want to make sure that even your NET expert got this right. And you may find another NET expert who's just closer to home than the one you just saw. And just want to tell you that for all cancers, rare cancers and common cancers, there can be multiple different ways to correctly treat or deal with a situation. So the fact that one NET expert told you this and another one tells you that does not mean that one is wrong and one is right. It's just that there are 2 different, or 3 or 4 or 10 different ways of dealing with things. But the problem is that the more opinions you get, the more recommendations you're going to get. And that can be distressing. So well, this guy told me to do this, but that guy told me to do that. So that's why it's really good to have like a quarterback NET expert who really is the person who you take those questions to and then you decide on what you want to do. So do I have to start therapy now? This is a question I get a lot. So no, not necessarily. So some of the smaller pancreatic neuroendocrine tumors we routinely observe. We haven't operated on a small pancreatic tumor now, or rarely for a long time. So pancreatic neuroendocrine tumors, well differentiated, less than 2 centimeters, we just watch. And they typically don't move. And well, if the tumors are causing blockage or bleeding or complications like that, yeah, we obviously have to do something. I have one patient I saw 6 years ago with the metastatic small bowel neuroendocrine tumor, very slow growing. So we've been watching liver metastases for 5 or 6 years now. Every scan, they look a little bit bigger, but they're still, the largest one is still smaller than an inch and a half. And he decided that we're not going to do anything about this, and he made exactly the right decision. Barely moving. There's no urgency in treating this. If he is okay living with a growing tumor in the liver and he doesn't need therapy to control symptoms, that's perfectly fine. When we finally decide to treat, it's not like he has missed out on anything. The difference in life expectancy for low-grade neuroendocrine tumors, whether you start early or late, is probably not there. So meaning that you can wait. Sometimes it's very appropriate to wait. So just a few of my rules for addressing newly diagnosed cancers in general, similar to what I said before. Did I get it right? Have I done the necessary workup? And what's the intent of therapy? Are we aiming for a cure, or is it symptomatic control or palliation? And then what do you want as a patient? And what are your goals, wishes, and things of that nature? So moving on to the last part, so different goals for different patients, obviously. So we have to be really honest with our patients in terms of side effects. All treatments have side effects. And what is tolerable or reasonable to you may not be tolerable or reasonable for another person. Balance the risks against the benefits. Be very, very honest. We should know the side effects of these treatments, but some treatments that are incredibly well tolerated for one person can cause a lot of grief for another person. So how do we sequence treatments in terms of should we start with this or that? We don't really know for a lot of our interventions. For most well-differentiated neuroendocrine tumors, injections with octreotide or lanreotide, or hopefully ultimately some of the newer oral drugs is a very appropriate start. And then be careful with financial toxicity, insurance coverage, and things of that nature, because financial toxicity is really real, as many of you know. And So what I often end with is that the whole greater than the sum of the parts. So let's say you have X number of treatment interventions, chemo, PRRT, some said analogs, and what have you. And if you put all of this together, let's say if everyone gives you like a year and you have 5 options, is your life expectancy going to be 5 years because you have 5 options, each work for a year? Or is it maybe much longer? And I would actually argue it's a lot longer. So a lot of the sort of the art of oncology is to know when to move and know when to sort of not move and just sit tight and not do anything. And I think that's where we get the best results. We play a card or two at a time, and then sometimes we just withhold and wait. And then I tell patients that your mileage may vary. So I have a patient who's been on everolimus for 5 years. It's the longest I've ever seen. So in the trials would say everolimus or Afinitor, it's like 12 months on average. 5 years going still. So, and then we're going to have a talk on clinical trials. So I'll just leave that to Dr. Johan. And that should be bringing us to the final slide here. So thanks to all of you for being here. Thanks to NCAN and other advocacy groups. All of the net or NAN providers that I didn't mention, and we docs get a lot of the credit, but it should go to a lot of other people. And then the researchers, so organizations, government organizations, and then pharmacy, or the pharmaceutical and biotech industry. There's a lot of this we could not do without them. So that takes you, that's my hometown, Reykjavik. So yeah, slightly colder than Miami.